Talk a little bit about update on fenestrated and aortic, fenestrated and branched repairs, endovascular. And really before we start venturing into that, we have to look at our different treatment options for thoracoabdominals and arch aneurysms, and these are the four that I propose that exist today. Well, how about medical treatment? This paper was presented recently at the European Society of Vascular Surgery, where they followed 201 patients that had thoracoabdominal disease and found 44% unsuitable for open repair for physiological reasons, and they were followed up at their general practitioners, and they found that at 11-month median follow-up, 49 patients had died, and a quarter of these patients here had died due to ruptures. So there's certainly a place for intervention, but there is also a place for not intervening on these patients, and it's hard to tell when to do what. Well, how about open repair? Well, the only real comparative or semi-comparative series in this fashion is the one from Roy Greenberg at the Cleveland Clinic, presented in 2006, comparing open thoracoabdominal repair and a concurrent comparison to endovascular thoracoabdominal repair. And what they found was really this, that the mortality was equal if you looked at the overall results, and for the more extensive disease 2 groups, the mortality was still equal, but as the previous speakers had mentioned, the spinal cord ischemia issue was significantly less for the endovascular cohort. And this was really the only significant paper published with a large number of patients from a single institution comparing these two methods of treating these patients. Hybrid repair was mentioned, and I saw my name flash by on the screen, and we presented a series from the Cleveland Clinic on hybrid repairs, and the results were frankly quite dismal. This is a meta-analysis done on this on 13 studies. As you can see, then only 58 patients, very high technical success, and these were the initial results. But as Martin showed you in the previous talks, time has told us that this might not hold out and hold true, because more and more data is coming out that this is really a procedure that gives the same mortality and complication rates as open surgery. So my message would be stay away from this. So moving into the main topic of my presentation, endovascular repair of complex or thoracoabdominal and arch aneurysms. Why do we need it? Well, as I showed you, a lot of patients are just simply too high risk for open repair, and the rupture risk seems to be high if we leave these patients untreated. The hybrid treatment, as said, is no less risk than standard open repair, and as we've seen for the infrarenal segment of the aorta, EVAR might offer less trauma and less ischemia time and faster recovery and less complications, or at least that's what we hope for. So this is a patient that presented to us with a thoracoabdominal type 4 aneurysm. You can see here measuring about 76 millimeters. This is just an MPR view from the side to see that pathology. And this patient was a 150-kilo man with previous abdominal surgery and significant risk factors in diabetes and whatnot. So we chose to treat him with an endovascular fashion. This was a couple of years back, and we chose to use a fenestrated device, that is an endovascular device with small holes for the branching arteries. So he had no left kidney, so we were going to put a covered stent in the SMA and the right renal, and the celiac artery we were going to occlude. It was highly stenotic, and we thought we'd just leave it out of the picture. So we came in and we'd put a proximal extension piece in first, and then we came in with our fenestrated device, and in a standard fashion for fenestrated devices, we catheterized the target vessels, and the completion angio was very nice. And I can tell you, this looks much better than it felt after having worked for about 12 hours to get this in place. And the patient suffered severely in the postoperative phase with a compartment syndrome of his gluteal region because of his heavy body weight. He had renal failure. He was paraparetic. And we'd had another couple of patients that were very technically difficult to implant the grafts, and we just found that the fenestrated devices were just not suitable for thoracoabdominal pathology because the positioning of the graft, as it happened in this case, was very unpredictable. It lay along the posterior wall of the of the aorta instead of the anterior wall, leaving the catheterization very difficult. It's very hard to precisely position and plan multiple fenestrations. If you have a single or two fenestrations, it becomes easy in a juxtarenal aneurysm. If you have 4 fenestrations in the thoracoabdominal, it becomes very, very difficult. And then you have to bridge a very long gap from the graft to the target vessel, and that gives the instability of the bridging covered stent, in addition to the very technically complex procedure. So we and others moved on to doing branch stent grafts, and here you can see these fenestrated holes in this graft, and to differ from this branch component. This is the a helical branch as conceptualized by Roy Greenberg again. And these come in various fashions and types, and this is for a thoracoabdominal aneurysm treated. Here you can see the helical branch coming off and a branch combined with different fenestrations. And the planning issue here is fairly complex. When you do your workup, you have to map out the aneurysm that you're going to repair, and you have to plan the branches accordingly, or at least that's what we thought initially. You can have various types of devices. This is a graft that we implanted last week with renal. These are branches for the renals, and this is just another case to show that. And what we get back is this ultimate graft plan that has, for this thoracoabdominal aneurysm in this patient with a previous infrarenal repair, then has branches for the different target vessels. And as we go in, we use an approach from the axillary artery, or rather the subclavian artery, where we approach this from above and access the branches and then access the target vessels and bridge the gap with long self-expanding stent grafts, and then reinforce them inside. And this is the end result in this patient, very nicely, very nice end result, very satisfactory. Another patient then that just sort of describes the complexity of these patients. They had a pseudoaneurysm in the celiac trunk with a proximal stenosis. He had bilateral common iliac artery aneurysms. He had separate left vertebral artery takeoff from the arch and a chronic dissection. So our approach to that was to revascularize the superficial trunks with the left subclavian artery and vertebral artery transposition. We embolized the celiac artery trunk because it was functionally already stenosed. We put a thoracoabdominal graft, and as Martin was saying previously, even though he had small aneurysms in his common iliacs, we weren't willing to sacrifice the hypogastric circulation because we were afraid that he was going to become paraplegic. So we put very large bell-bottom limbs in the iliacs to preserve the hypogastric circulation. I'm afraid that this probably won't work either. This is just an image of that aneurysm, so I'm not going to show you that. Here you can see after the debranching procedure in this patient, the bypass, the transposition, and the vertebral transposition in this patient, and the first part of the stent graft coming in, the coil of this large pseudoaneurysm in the celiac artery that we coiled perioperatively, and then put the branch component in, and this is the end result for that patient. And you can hardly see, but these very large bell-bottom limbs done. So what are the results of endo repair for thoracoabdominal aneurysms? Well, these are the series that are out there. Greenberg, as you can see, sort of skews the data a little bit with his very, very large numbers, but the technical success seems reasonable in all these high-risk cohort of patients with a reasonable 30-day mortality and low paraplegia rates. So it's technically feasible, and the early results in high-risk patients are encouraging, but procedures are very technically demanding, and we need better equipment to do it. A good case on the horizon is the fact that we now found that because of technical issues, 8 out of 10 of these patients will have to actually fit in an off-the-shelf graft, so we don't have to customize it for each individual patient, and that will be a major step forward for us. It's still developmental, but I think that in the future it will probably offer to more patients because of the reasons I've mentioned. So how about the aortic arch? Well, problems in the aortic arch, of course, with available stent grafts is the poor conformability of these grafts, and that the left subclavian artery preservation is critical in certain situations. If you don't have a proximal seal in the descending thoracic aorta, you have to incorporate your neck vessels. And you can do this with various techniques. This chimney technique, as you've probably heard of, we use in the acute setting mainly because we can't have a branch graft or a fenestrated device ready for the patient. This is a patient with a dissection, and you can see if you put a standard graft in, it's not going to sit well in this curve. So I opted to push it forward a little bit and put a stent, a coverage stent through the left subclavian to bridge that forward and to preserve the flow in the left subclavian. And the result is actually very good after 2 years with good patency. And this is the end result in that patient. You can see here we put a graft come from the arm and then just extended to get a little better landing zone. Now this looks very odd when you look at it on a CT scan as that graft pushes the thoracic graft. And you need to remember, if you do this, you need to have a seal distal to that branching artery, because the graft will not seal here. Now this is a dissection, so the only thing we wanted to achieve was to close the primary entry tear, and in that situation it works well. And this is actually, I could have shown you in identical pictures at 3 years follow-up. It hasn't changed at all, and the dissection is completely gone. We've pushed this forward in other acute, and all these are rupture patients or acute dissection patients or contained rupture patients of various aneurysms that were turned down for open surgery, where we've done the same. In the more elective setting, of course, we can put holes and fenestrations here, just as we've done in the thoracoabdominal segment, and then we can catheterize either through the graft or come from the arm or from the neck and go into our graft to complete the procedures. And this is one such case, as you can see here. And this is the end result. When it comes to branch stent grafts, of course, the orientation issues and the deployment issues are difficult. Instead of rerouting the neck vessels, you can use a bifurcated component and place that in the ascending aorta as a standard bifurcated graft, and then extend your repair with a standard stent graft downwards and do neck deviations. And this is the patient I showed you in the previous talk as well with this aneurysm. And you can see the end result here with him with this bifurcated device here, and then carotid left subclavian bypass. And our latest venture in this arena, which we find having great promise, is this. This is the patient came into us with he was a Jehovah's Witness and refused blood transfusions, was turned down for this penetrating ulcer at 2 institutions of cardiothoracic surgery. Didn't want to repair him. So we took him to the OR. We placed carotid conduits bilaterally on him and shunted him from the femoral artery. We had a little centrifugal pump here to help him, but he was actually quite stable, so he managed almost to pump on his own, and we cooled it at the same time to keep cerebral perfusion. And then we put a graft in while his brain was perfused and stuck covered stents in through the neck vessels down, puncturing the graft and putting them in the main body of the graft to complete the procedure. And this is what it looked like at the end of the case. And this is the 6-month follow-up on this patient, and I met him a couple of months ago. He was doing fine. So I think this technique has a lot of promise, although there is a lot of work to be done in this region, what happens to these stents and what happens to the graft in the long run. So in my mind, we're moving closer and closer to achieving total branch and fenestration techniques in the elective setting, both for thoracoabdominals and for the arch, and in the acute setting, and might even be in the elective setting if we can develop the grafts in that direction. And situ fenestrations is very promising because it's technically very much easier than getting all these catheters and wires in place. Thank you.
Thanks, Tim. Any questions from the floor? Very impressive series of clinical cases there.
Yeah, maybe you can tell us how you penetrated the grafts, just with a stiff wire or a laser or...
No. What I did was I used a long, it's called a special needle. It's just a puncture needle, but it's very sharp. So when we had the carotids out and the conduits, we just punctured, put a sheath down in the standard fashion right to the graft, and then put the needle through the graft. I mean, it's a very short distance, and you could puncture it. I didn't show you all the images. Then you can get a 14,000 wire through, put a small balloon in, and then work your way up.
Okay, thank you then. That's the end of this session. We'll reconvene at 11 o'clock. Just to say thank you to all the speakers and the commentary from your